Hello, everyone. I'd like to welcome you to this Cardiovascular Research Foundation webinar on innovations in temporary pacing, the BioTrace Tempo Lead. My name is Tamim Nazif. I'm an interventional cardiologist at Columbia University Irving Medical Center. I'm joined today with an excellent panel. I have my friend and colleague, Philippe Généreux from Morristown Medical Center, also an interventional cardiologist, Dr. Stan Chikuti from the University of Michigan, another experienced interventionalist, and Dr. George Hansel from Emory Medical Center. I'm going to begin with a brief overview of the technology. I'll then turn the presentation over to my colleague, Dr. Généreux, who will detail his experience and practice with the Tempo lead. And we'll then have a discussion around the various points raised. So first of all, why do we care about temporary transvenous pacing as interventional cardiologists? And the reason is that the use of these leads has significantly increased as we've adopted more and more structural heart interventions. And when these leads don't function appropriately, it can lead to important complications. For example, from my own experience shown here, to the left, a loss of capture resulting in a transcatheter valve embolization, and to the right, a right ventricular perforation leading to cardiac tamponade. And so this is an often overlooked but really critical step in many of our structural heart interventions. We know historically that temporary pacing leads have been associated with significant complications, including things like cardiac perforation in up to 4%, and dislodgement or loss of capture in up to 35%. Multiple studies in the TAVR populations have shown that these complications exist in our procedures as well. The Tempo temporary pacing lead is the only active fixation temporary lead available on the market. It's purpose designed for secure and stable pacing with a specific goal of reducing procedural complications, as well as allowing and facilitating patient ambulation and recovery. It has design features, including a unique soft tip that can mitigate perforation and stabilizers that provide secure active fixation for stable pace capturing. And I'll show these features in more detail. The lead itself is 6 French. It's shapeable. As I mentioned, it features this soft atraumatic distal tip. There's an asymmetric elastomeric balloon that functions to oppose the lead during deployment to the septum. There are then radiopeg orientation markers, small stabilizer loops that can be deployed and retracted with the use of a handle. It's compatible with all available external pace generators and FDA cleared for up to 7 days of use. Here's a brief animation that shows the use of the lead. Entering through the venous system, either from jugular or femoral access, traversing the tricuspid valve with use of the balloon. Once it reaches the RV apex, again with the soft lead to mitigate the risk of perforation, the orientation marker can be shown by fluoroscopy to be directed correctly into the septum. The lead is opposed with use of the balloon, and the stabilizers are actuated using the handle. At this point, we have active fixation of the lead, which is held in place by those small nitinol loops. They're smaller than a coronary wire and therefore very atraumatic. They can stay in place, as mentioned, for even days and can be removed then by simple reversal of the handle and withdrawal of the lead from the venous access. We studied the initial United States experience in a retrospective study along with Dr. Chikuti and others. This included 250 cases from high volume sites in the United States, mostly TAVRs, about 90%, including a mix of both self-expanding and balloon expandable valves, notably also with 5% alcohol septal ablation and other procedures. In 98%, Tempo lead placement was successful. This was both from jugular and femoral venous access. The pace capture thresholds were very favorable at 0.7 milliamps, and loss of pace capture occurred only in 2 instances, a very low, less than 1% rate. In this study of, again, more than 250 patients, we recorded no perforations or clinically evident pericardial effusion, device-related arrhythmias, or other notable procedural complications. Interestingly, we also looked at patient recovery and showed that in 71% of the cases, the tempo lead was left in post-procedure. The mean of this was almost 2 days at 45 hours. The pace capture threshold remained very favorable at less than 1 milliamp all the way through removal in the patients where it was recovered. And many of these patients were not only up to the chair, but even ambulating with the lead in place, demonstrating the safety and feasibility of that. I'd like to share then a couple of our cases from Columbia University from that retrospective study. The first case I'll share is a case of temporary pacing with the tempo lead during TAVR. This was a patient of mine, a 76-year-old woman with symptomatic severe aortic stenosis and elevated surgical risk, who was evaluated by the heart team and scheduled for transfemoral TAVR with SAPIEN 3. This patient had the tempo lead actually inserted from the left femoral vein. I like this case because it highlights that the tempo lead can be placed both from internal jugular venous access, as is often done, but also from femoral venous access. And there's actually a curved lead specifically shaped to facilitate entry into the right ventricle from femoral access. You see in the picture, the balloon is inflated. We often inflate it halfway to cross the tricuspid valve. We then advance the lead to the right ventricular apex and use the orientation marker to show, as seen in the right panel, that the stabilizers are directed into the septum. We then inflate the balloon again to oppose the lead to the septum, deploy the stabilizers with simple actuation of the handle. The balloon can then be deflated. The lead is then actively fixed and allows for safe, reliable pacing during, in this case, balloon expandable TAVR deployment. This patient started with normal QRS and conduction, which is why we had done it from the femoral axis. The EKG remained stable and unchanged at the conclusion of the procedure. We therefore removed the tempo pacer in the room. This is simply done by retracting the stabilizers using the handle, simply reversing the motion, and withdrawing the lead through the venous access. I'd like to show one additional case, making the point that the lead can be used in structural heart procedures beyond just TAVR. This was a 61-year-old gentleman with COPD, fairly advanced, making him high risk for surgery, had hypertrophic cardiomyopathy with significant symptoms despite maximal medical therapy, had a high gradient as shown here, and was planned for an alcohol septal ablation. We did this as shown here by the typical technique with LAD access of the first septal perforator, alcohol injection, and so on. Did it with a temporary pacemaker in place using the tempo lead, in the anticipation that most frequently in this patient population, we leave the pacemaker in place for a period of time to monitor for late heart block. This patient did in fact have a new right bundle branch block, and the lead was maintained for 48 hours with very good capture thresholds, 1 milliamp after the full 2 days later, 1.5. Beta blocker was initiated, had no progression of conduction disturbance, and the lead was ultimately removed. But just a nice example of the use of the lead in one of our procedures. So in conclusion, I think the tempo lead offers us significant potential benefits for our structural heart procedures. It is designed to provide safe and stable intra and post-procedural pace capture. This can include during recovery, out of bed to the chair, and with ambulation. The real-world perforation rates, again, none observed in the study, 0.04% in BioTrace records, may enable patients to enjoy expedited recovery pathways, often bypassing the ICU, and may result in a reduction in length of stay and other attendant economic benefits in the right setting. So I'll stop there then and turn it over to Dr. Genera, who will detail his experience using the lead in his practice at Morristown Medical Center.
So thank you very much, Tamim, for such a great background of the tempo wire, and it's a pleasure to be here among you today. I will speak on behalf of the Morristown Medical Center TAVR program or structural heart program and summarize a little bit or use of the Tempo BioTrace lead for different application, but mainly TAVR. So, but before we start, I just want to summarize the very important paper that has been published in 2019 by Josep Rodés-Cabot and other co-authors, including Tamim Nazif, which is with us today, about the management of conduction disturbance associated with TAVR. Obviously, it's a consensus of experts, and I believe Tamim will agree with me that we are very far from a consensus, from a definitive consensus, but at least we have some rules or general guideline. And I want to share this central illustration of the Jack manuscript that kind of summarize a little bit our approach for a TAVR patient. Obviously, everybody should be assessed for any type of procedural risk, including anomaly in the conduction disturbance, either left bundle branch block, right bundle branch block, or sick sinus syndrome. And after the TAVR, obviously taking into consideration what happened during the TAVR procedure, either complete AV block or new left bundle branch block, it is mandatory to have 12 lead EKG and a telemetry. And then they propose different pathway depending on the EKG. I would like to focus on the right side of the screen, actually, where which patient should have, I would say, a prolonged monitoring with a temporary pacing left in place for 24 hours. And these patients include patient with pre-existing right bundle branch block, and we're going to talk about that. Patient that EKG changes after the procedure or during the procedure, either new left bundle branch block, and Tamim know exactly how frequent it is after TAVR, or any high degree AV block during the procedure, or complete AV block with need for pacing. I think one of the key aspects of this, obviously, this is really some guidance, but after 24 hours or an overnight stay, we reassess actually what is the next step. If there's a resolution of the conduction disturbance, well, we can remove the pacemaker and potentially discharge the patient, and we're going to talk about that later. Or consult our colleague in electrophysiology and conduct more advanced studies, or implant a pacemaker. But I really want to focus on these patients that we could identify as high risk for new conduction disturbance or AV block, which is mainly a right bundle branch block, or changes during the procedure. I would say that I have a lower threshold in these recommendations, and I want to share as a base for discussion what we're doing at Morristown Medical Center, and we're very fortunate to have a great heart team, and we do approximately more than 600 TAVR years, and we adopted the Tempo wire for approximately 40% of our patients. And this is where I, right out the gate, plan the case with the Tempo wire, which is obviously when there's a baseline right bundle branch block, when there's a baseline left bundle branch block, when there's a first degree AV block, when there's a sick sinus with slow AFib less than 60, and also other indication when there's severe LVOT calcium on the CAT scan, and we can discuss that after. When there's severe MAC, we learn both from the literature, but also from experience, when there's a lot of calcium, this is a strong predictor of new conduction disorder and also AV block. So I'm very, very sensitive to that. So I use the CAT scan to plan the use of the Tempo wire. When I have a young patient, for example, and I'm planning to use a big valve and to maximize the hemodynamic of the valve, well, and I'm oversizing aggressively, I use a Tempo wire from the neck, because there is more conduction disorder with the use of oversized valve. And also, you share a nice case, Tamim, but I think when the jugular central line is used, when my anesthesiologist said, this patient is unstable, he has a low EF, this is a complex case, well, I just use a Tempo wire from the right jugular approach. So when these characteristics are there, and you can obviously assume that this is at least 40% of the patient, we decide to go from the right jugular approach and to put a tempo wire because we want these patients to ambulate, and we have higher risk of new conduction disorder that will need prolonged monitoring. What is the flow of our patient at Morristown? And I'm pretty sure, like any other large program, well, we do the TAVR. We do a little bit of conscious sedation, but we're still heavy on general anesthesia and TE guidance. So we have an immediate recovery, 2 to 4 hours in the recovery area. Could be CCU, could be surgical ICU, but could also be the cath lab recovery area for 2 to 4 hours. If the patient is stable, is go right away to the floor with telemetry, where we can ambulate the patient 4 to 6 hours and maintain the temporary pacemaker overnight through the neck, where the patient can directly ambulate 6 hours after, and that's the advantage here. So we can facilitate ambulation and a regular floor. And this was true, especially true during COVID time, where we don't completely bypass actually the CPACU or the CCU, and we were observing the patient in a recovery area for 2 hours and everything was okay. We send directly to the floor with the tempo lead, bypassing the intensive care. One of the key aspects is most of the patients are presented with some sort of high-risk feature for new conduction disorder or conduction disorder at baseline. We'll leave also with a ZO patch monitoring, and we can talk about that on this discussion, giving their chance to progress. So we adopt a kind of early discharge strategy, but with some sort of safety net with a ZO patch XT. So this is our approach, and I will be happy to discuss a little bit with the panel and the panelists other way to do things. So I will stop there, and thank you again for having me.
That was a really outstanding presentation and just a tremendous amount of good guidance and issues to delve into and discuss. Dr. Jakuti, I know you've also had significant experience using the lead to facilitate expedited recovery of your patients, an expedited recovery pathway at Michigan. Could you take us through how that works?
We're deeply involved in core valve trials when the pacing rates were still on the higher side. So we felt it was not worth to try to be selective. We just use it on everyone. There was also an element of self-preservation, I would say, because when we used these, once the old Medtronic screw and pacer was lost, so this was the only active fixation, the amount of times that we would have to come in was not insignificant. And coming in, 2 techs, a nurse, call team, once you come in, it's 2 hours overtime. This was way much cheaper and much better preservation from our part. So as we become more sophisticated with newer techniques, and our pacing rates are now in the low single digits, we have adopted more and more what Philippe is doing now with selecting the right patients. We do all our patients are conscious sedation, but our anesthesiologists tend to use dexmedetomidine, which tend to have some conduction disturbances. So you don't want to jump the trigger too quickly, and it's good to have an active fixation. We go IJ for everyone, but because we go IJ and they're mostly light or moderate sedation, it is our goal to have them ambulate within 2 to 4 hours, and with the pacer still in. If there's anything that suggests that there's any concern, we leave it overnight. If you have to challenge with beta blockers the next day, very similar to what Philippe said. And then we are now adopting the ZIO patch real-time telemetry. So the median length of stay for our group is now 24 hours as well. But this allows us to be much more aggressive and test the beta blocker challenge earlier and emulate earlier. I would say over 95% of our patients are recovered in a non-ICU step-down type unit, moderate care unit. I would even add that in the COVID era, as beds became a premium on the regular floor, our recovery area in the cath lab became a sort of an emergency hospital bed type situation, and most of our patients were being recovered in the PAC lab, usual place where we recover our outpatient observations. And so, testament to how safe it is that there's never an ICU setting for these patients, all step down.
Dr. Hansel, I know you as well had fairly extensive experience with the lead with Beaumont. Could you talk also about, did you use it universally? Did you select patients? What was your experience in patient selection and procedural issues?
Yes, well, maybe I'll just share how I kind of grew into the tempo lead over time. So I think my experience has been going on for 3 years or so. And initially it was very selective and really used it for high risk patients, right bundle branch blocks. And as I got more and more comfortable with the lead over the course of a month or two, I had a complication. And it wasn't with tempo lead, it was with our regular pacing lead as a lead that we kept in overnight, and the resident pulled it in the CCU the next morning, and they had a tamponade, and that can sometimes be a little bit of a fire drill in the CCU on a early Saturday morning. So with that, I thought, with the incredible safety record with the tempo lead, I started using it more universally. And so we're at a point where we would, just have a, IJ line and put a tempo wire in basically everyone, nearly everyone. And I think it's particularly important because our TAVR days were kind of Monday, Thursday, and Friday. And so particularly with a lot of people on Fridays, if you did get into trouble, it's
Sure.
nice to have a secure lead with a good, pace capture threshold that you can really rely on, still get the patient out of bed and walk, and get a pacemaker Monday morning. And so with that, we became very reliant on the lead from our experience and been incredibly happy with how it performed.
Great. And does anyone want to maybe touch on, let's talk a little bit about the procedural issues, and then we'll talk more about the recovery and ambulation and so on. Does anyone want to talk about sort of what's involved? Is there a learning curve to place this? Is it challenging, femoral versus IJ? What's been people's experience placing these leads?
Yeah, I can start. I would say that I never been really impressed by the learning curve. I mean, it's pretty intuitive, to be quite honest, especially by jugular. I mean, it's easy to cap. I mean, there's no rocket science here. I mean, maybe you need to twist a little bit clockwise or counterclockwise a little bit. What I find useful is I inflate the balloon halfway just to get into the RA and the RV, and then I deflate. And then I feel that when I deflate, it dove a little bit. I have a tendency to dive. And then I inflate the balloon, and when I'm in the correct position, trigger the anchor. So it's pretty straightforward. Maybe 1 or 2 cases of a learning curve, but it's pretty intuitive. The other thing is obviously you need to follow the 2 marker, but I feel that it's very forgiving. Even if you're not in the perfect optimal position, it's still better actually than the standard pacemaker. And I've been impressed with the threshold that are really low actually, which is reassuring in many ways. So from the femoral approach, I don't have much experience. We use it a couple of times. Same concept here, maybe a little bit more challenging, but again, not really that challenging. So
I would agree. We did some cases femorally, and it's I think a touch more challenging. But I like the IJ approach because, particularly if you're worried you want to keep the pacer in a day or two, certainly you can get the patient up and moving and walking rather than laying flat and, having a line in the groin, increased risk of bleeding. And I think from the IJ, it's really a pretty straightforward implant. And to tell you the truth, after proctoring a fellow a couple of times, they've got it. It's pretty straightforward.
Yeah, I mean, I think it speaks to the safety, the fact that you're freely letting the fellow place it, talks to the relative forgiving nature of the lead. We have done a fair number. I agree with you. It's nice to put them from the IJ if you're planning to leave them in. We've had a fairly broad femoral experience with them as well. And it turns out that there is a lead curve available that can help make it even easier to place, especially if you're coming up from left femoral, which might otherwise be a little bit tricky. And we found that to be helpful in terms of the initial positioning when coming from femoral access. But either way, I agree that while there may be a very slight learning curve, it's pretty darn minimal, and the lead in the majority of cases can be placed from IJ or femoral, and it seems to be pretty safe and forgiving from either approach. I agree with George though. It seems a little counterintuitive if you're planning to leave the lead anyway to put it from femoral access. So, I mean, you may well still do it for safety or some other reason, but if you're going to leave it in place anyway, it seems nice to have it in the IJ, and then we could take advantage of, I think, that the next thing we're going to talk about, which is some of the recovery pathway, and I think Philippe and Stan and others alluded to sort of, especially during COVID, but even before COVID, this increasing push towards obviously minimalist, but not just that, the expedited recovery, pathways, bypassing the ICU, going to ordinary wards in the hospital. What's been your all experience in terms of leaving it in and ambulating the patients and so forth?
again, I will start, but I think it's very good experience. I mean, we did a fair amount of case. I don't know how many, but probably more than 200, 250 annually, but we didn't have any tamponade. And speak to Dr. Hensel point is, I remember vividly a complication with a low risk patient where we went from the groin and we had a perforation to the RV lead, and it was totally unanticipated and totally unexpected. So make me think actually that maybe we should always use a tempo lead from the neck, and because there's an element of unpredictability. So, but that being said, patient, keep the lead in the neck and walk on the floor. We didn't experience any issue with the loss of capture or any issue with perforation. So, and by now the nurse staff and the floor staff are totally used to that. So, for me, it's a no-brainer, and we didn't have any issue. And I think it's key, especially in older patient, rapid AFib. You want to adjust the medication. You want to push the beta blocker, like it was mentioned. Heart failure, same thing. I think these patients need to ambulate to avoid delirium, etc. So I think it's part of the care, optimizing care. It's not only for high-risk patients, it's just optimize the care in general to allow early discharge.
Yeah, I would agree. And it took us a little bit of time to really get our nursing staff comfortable with ambulating the patient, but pretty quickly they adopted. And I think it's key. That's one of the reasons I really like the tempo wires, to be able to ambulate the patient so they're not stuck in bed. Since early ambulation is really so important for the care pathway of these patients.
And someone mentioned this already. I mean, although I would say over 90% of what we do is for TAVR, but alcohol septal ablations are a good subset. And I tend to leave those patients with at least 48 hours of a lead. And I would like to comment that the thresholds are great to begin with, but they're consistently not significantly different, even 24, 48 hours up to the implantation. So it's testament to how good this lead really is.
Yeah, I would second that. To me, that was a great case you presented. We routinely use it for all of our alcohol ablations. And I agree, some of these patients, when they develop heart block, they don't have much of a ventricular escape. And so you really need that lead, and you really need a secure lead. So, really, use it for all of our alcohol ablations. And, some of the patients, you might leave it in for, 3 or 4 days even. And I think it's critical to be able to have it in the IJ and be able to ambulate the patients.
Yeah, I agree. It's nice to have that flexibility to get those hypertrophic cardiomyopathy ablations out of bed, because you're right, they can stay in sometimes several days. And I remember for the years in our initial experience, they'd be flat on their back in the ICU for days, and it's we know that's clearly a decrement to the recovery of the patient. So I absolutely agree. Well, that's great. I think one issue that has been coming up for us a lot is, again, sort of how to predict and manage the conduction disturbances. I think, as Philippe said, we have some consensus documents. He shared the one from the JACC expert scientific panel. There are clearly other algorithms out there, but we've gone from being completely unable to predict these things. Now we can not only in some cases predict conduction disturbances, but understand which ones are most dangerous. And, is it the pre-existing rights? Is it the new left bundles, PR or QRS prolongation? To what extent are you guys relying on those predictors and kind of being selective versus a more general pathway? I'm curious to see how that practice has evolved over the years.
Yeah, well, one thing from the guideline I really take verbatim is a QRS more than 150. I can tell you, when I start a case with a QRS more than 150, I go for sure tempo lead, and these patients are really scrutinized after. And I find actually that these guidelines are a little bit too permissive, to be quite honest, because yes, the right bundle branch block is the main driver, but I can tell you there's a lot of pacemakers that occur and a lot of high degree AV block that occur with no conduction disturbance at all at baseline, or only a left bundle branch block. So obviously, depending on the prosthesis and like I mentioned, sometimes the calcium, how bulky is the calcium, bicuspid, etc. So I think this algorithm, this consensus is really a bare minimum. where I'm very frustrated on a daily basis is how to discharge this patient. You know, and this is where we start to use Zeo patch, not much because we can treat them. You can have a pretty AV block and a 10-second pause on the Zeo patch, but there's no treatment. You get a phone call. But the problem is, we need to be better to predict these. And so when you observe the patient in house, I think to have a tempo lead is very useful, because most of the time we ask electrophysiologist colleagues, and it's how we want to observe a little bit more and a little bit more and a little bit more. And at some point we need to take a decision. And so that's the reason why to have the luxury of the tempo lead, that's great. And sometimes we get burned. We start femoral leg, regular pacemaker lead, and oops, we have a complete AV block during the procedure, a new left bundle branch block, and end up changing for, all right, put a neckline and put a tempo lead. So we got burned a few times. So that's the reason why we can become a little bit more permissive with these recommendations. And my threshold now is so low because I got burned a few times.
I wish I could say I'm as sophisticated as you, Philippe, but we just basically use it in everyone, because the pain of having to convert from the leg to the neck, and when you're trying to do 4 or 5 cases and you're bouncing from room to room, and that always throws a curveball at you, and you're a bit slower. Just do it up front when it's controlled, and keep going with it. And the quick ambulation makes a big difference to us. One of the things is we have been quick to the trigger. Again, we were like George, we do a lot of cases on Friday, and you don't want to wait all weekend for it. If he's not going to come in on the weekend and do a pacemaker, so it'll be 2 or 3 days. So we were quick to the trigger, but we realized that many of our patients have got paced very early, and we've published these data that 30 to 40% are not being paced at 6 months to 1 year. So maybe if we had waited a bit longer before we jumped the gun to put a pacemaker in, we could have avoided that. I do like your idea, the Zio patch, BioTel, whatever your flavor is. Yes, you can do much, but a phone call sometimes save them from coming in 3 or 4 days later with some even higher degree block. So we found that very, very helpful. And in the last 6 months, we've had 2 or 3 that came back that needed some higher grade pacing.
Yeah, it's a very interesting discussion. I completely agree. And it shows, I think, that there's not necessarily a one size fits all approach. It's going to be sort of based on the site, the individual practices, the resources, and so on. But I think clearly there are some people that it may benefit to use it in every case, and then other programs that may sort of be a little more selective. One issue that comes up is sort of cost and the economics, and I've reviewed that with our program. That there are trade-offs. The point I always bring up is that these complications, although they're relatively rare, can be exceedingly expensive when they do occur. You only need one perforation or one, these embolizations or some of these significant complications can be very costly. So, I mean, how do you guys think about sort of the economics around this issue?
I think the difference in price is so minimal, to be quite honest, that it's almost a non-issue. To be like, it's not like other device or technique where, you talk about Sentinel, for example, or I mean, this is like, you talk about $4,000 or whatever the price is. This is not the case at all. I'm not even sure what is the difference, but it's barely a couple of $100. So to your point, ambulation, length of stay, tamponade, and switching access, and so I think this is a no-brainer. It's we talk about dollars here. We don't talk about thousands of dollars.
I mean, we had done an analysis, and just saving 1 out of 20 readmissions. I mean, call back to float a pacer after hours with a full team coming in. The complications you mentioned, and we're like, I mean, on the East Coast, you're the best at getting reimbursed for these procedures, but in Ann Arbor and Michigan, we're also very good. So I understand for us, it makes no big difference, because the money is, as Philippe so eloquently said, is not that big a difference. I don't know if in other areas where the reimbursement is different, that they might get into the weeds and sort of, this becomes more, you might need to be more selective, but I think for us, it's not worth even considering to be selective.
Yeah. And I really have nothing else to add, because that's the exact same perspective we have. If we can save one complication, it pays for itself very quickly.
Yeah, I mean, some of these complications are sort of these never events too, right? It only takes one embolization that stays in your mind for quite some time, and you'll go to great lengths to avoid it if you can. So I agree that. Okay, great. Are there any other comments about sort of the use of the lead, or any tips and tricks? How would you if say there's a new site that's thinking about bringing this into their practice, what's the best way to sort of begin this? Just bring it in, help from the company, a proctor. What's necessary to start with this lead?
I would say from my humble experience, I mean, it's there's no rocket science there. I just have to start and do it, and the local rep are pretty knowledgeable. And I mean, you can obviously call a eye implanter guy, or implanter, but I mean, I would say that's really the to inflate the balloon halfway for me made a big difference in my maneuver. I don't think that's reached the threshold to get a proctor here, but I'm sure you just need to watch a video and talk with some colleagues. But it's really, learning on the spot. There's no really learning curve for this, so just do it. Yeah.
I would totally agree. I think it's a pretty straightforward implant, and I definitely don't think this rises to the occasion of being a proctor. But the reps are, I think, fantastic to be able to walk people through and show some of the way the device works and some of the tips and tricks for implanting it. But it's really pretty straightforward.
You're all absolutely right. I mean, the field team is great, and compared to the early days, something very, very simple was the new cheater device that they've come in, because the tip was very flexible before. And you remember, to me, we had to try and make sure you go perpendicular and hit it perfectly.
Yeah.
Now they have the little piece of plastic that goes in beautifully, and it's not even 1 second of hindrance. It's just like George, our fellows do it. See one, do one, teach one kind of thing.
Yeah, I think I agree with that. That's sort of the way to sum it up. See one, do one, teach one. It really is a very straightforward implantation. So I agree. I would encourage people who are potentially interested to give it a try. And I think very quickly you can get the sense of it. Okay, well, I think we've touched on the points that we wanted to cover regarding the tempo lead. I think it's been an important innovation in our practice, and again provides for safe and effective interprocedural pacing, allows the lead with active fixation to be maintained in place, allows patient ambulation and expedited recovery pathways, and may have clinical as well as potential economic benefits. I really thank the great panel for joining us. It's been a real pleasure, Philippe, Stan, and George, and I look forward to seeing you all in the near future and continuing these great discussions. I thank everyone for taking the time to join us, CRF for facilitating this, and BioTrace for their sponsorship. Thank you.
Thank you.